Hi, I'm Sandy Werner, and this is the Access EM video for cannulation of the internal jugular vein using ultrasound guidance. And this is Dr. Dan Haggerty, who will be performing the procedure. Traditional external landmarks for the cannulation of the internal jugular vein are the medial and lateral heads of the sternocleidomastoid muscle. The internal jugular vein and the carotid artery course within the triangle formed by the two heads of the SCM. In most people, the internal jugular vein lies lateral and anterior to the carotid artery. For the traditional middle approach, the needle enters at the apex of the triangle and is directed towards the ipsilateral nipple. For the posterior approach, the needle enters at the posterior aspect of the lateral head of the SCM and is directed towards the sternal notch. As we all know, the vascular anatomy can be somewhat variable, and sometimes external landmarks can't be seen or felt. So with ultrasound, we use the same approaches, but we can actually see the underlying anatomy and guide our needle into the vessel, eliminating a lot of poking around in the patient's neck. And in this ultrasound image, you can see the internal jugular vein, labeled IJ, the carotid artery, and on the left side of the screen, you can also see the thyroid tissue. Prior to an attempt at cannulation, both the right and left internal jugular veins are examined by ultrasound using the linear transducer for size and patency. The vessel is compressed to make sure that there's no clot in it, and we examine it for its overall size. Once we've looked at the right side, we'll look at the left side. Traditionally, the right IJ is preferred. However, if it's very small, we may actually use the left internal jugular vein to place our line. The decision to use a posterior or central approach is determined by the relationship of the carotid artery to the internal jugular vein. In this first illustration, the carotid artery is adjacent to the IJ. As you can see, if we use the middle approach, the needle goes into the IJ, and if we were to go accidentally through the back wall, no harm will be done. On the other hand, if we use the posterior approach, as seen here, the needle could go through the IJ and into the carotid artery. In this second illustration, the carotid artery is immediately posterior to the internal jugular vein. Here you can see using the middle approach might be a problem, as we could go directly into the carotid. If we use the posterior approach, as in this view, no harm will happen. We'll demonstrate the middle approach first, using the right internal jugular vein. Dan is having the machine positioned so that it's at the patient's right side, and the screen is in his direct line of sight, so he does not have to turn his head while he's performing the procedure. The patient has been prepped and draped in sterile fashion, and now we need to prepare the transducer. Dan is opening a sterile kit that contains a sterile sheath, which will be applied over the transducer, gel that's also sterile that will apply on the outside of the sleeve, and 2 rubber bands for securing the sleeve on the transducer. Dr. Jessica Resnick is now preparing the transducer by putting non-sterile gel on the transducer head. Dan has folded up the sleeve much like a sock, and now Jessica drops the transducer into the sleeve. Dan smooths out the sleeve, and he stays sterile. He applies the rubber bands, one near the top of the transducer and one further down on the cord, to keep the transducer cord sterile. He'll smooth out the gel underneath the sleeve, and then he can apply the sterile gel to the top of the transducer. Or he can wait and do this when he's ready for the procedure. And now we can actually lay the transducer on the sterile field. Now Dan is back in position at the head of the bed. We're going to proceed with the middle approach to the IJ. He's going to place the transducer on the patient's neck with the indicator towards the patient's left side. The transducer will be placed slightly above the clavicle, with the medial or indicator side slightly angled towards the patient's feet. And he'll check the location of the transducer by depressing the skin on the right side of the transducer, while looking at the ultrasound screen to watch the corresponding deformation of tissue on the right side. On the ultrasound screen, the thyroid can be seen to the left, or on the medial aspect of the patient. The pulsating carotid is slightly laterally, just below the thyroid, and then the internal jugular vein is to the right. The vein is usually larger and can be enlarged with a Valsalva or by placing the patient in Trendelenburg. Don't press too hard on the transducer. Even slight pressure will compress the vein and make access very difficult. For the middle approach, the transducer is positioned so that the vessel is in the center of the screen. The skin just above the transducer is depressed with a capped needle just to mark the position of entry. At this point, Dan will take the syringe filled with local anesthetic, and he will inject just on the lateral border of the medial belly of the sternocleidomastoid muscle. On the ultrasound screen, you'll be able to see the anesthetic being deposited into the tissue. Now that the skin and the subcutaneous tissue is anesthetized, we're ready to proceed with actual cannulation of the vein. With the vein directly in the center of the transducer, the needle is inserted along the same path as our anesthetic with the bevel pointed inferiorly. It's inserted approximately 1 centimeter above the transducer. The transducer is angled towards the needle tip so that it's visualized just after it enters the skin. This is the tricky part of ultrasound guided lines. Both hands have to work together to keep the needle tip visible during its insertion all the way to the internal jugular vein. Do not continue to insert the needle if you cannot visualize it in the near field of the ultrasound screen. Once the needle tip is under the skin, you'll continue to follow it as it approaches the anterior wall of the vessel using small jabs of the needle in order to avoid dragging subcutaneous tissue towards the vessel. As the needle approaches the vessel, the anterior vessel wall would deform or tent slightly. Proceed with a short jab to puncture the vessel wall. Once the needle is in the vessel, aspirate blood into the syringe to verify vessel entry. At this point, have an assistant freeze the image on the ultrasound screen and save it or print it for chart documentation. Now you can lay the transducer across the field, and the line is placed using standard Seldinger technique. Now that we've demonstrated the middle approach, we'll move on to the posterior. Dan has placed the machine on the patient's left side, so once again the screen is in his direct line of sight as he cannulates the right IJ from the posterior approach. The patient has been prepped and draped, and the ultrasound is already in its sterile sleeve. The ultrasound transducer is placed just above the clavicle in nearly the same position as used for the middle approach. Once again, the transducer indicator is towards the patient's left side. Indenting the skin on the right side of the transducer while watching the ultrasound screen for the corresponding indentation of the tissue confirms that our transducer is in the proper orientation. In this patient, the skin and subcutaneous tissue have already been anesthetized, and we're ready to proceed with cannulation of the IJ. The needle will be inserted with the bevel pointed inferiorly towards the feet. It's inserted into the skin in the center of the short face of the ultrasound transducer. The needle tip and the length of the needle will be visualized during their entire course into the IJ. If you can't visualize the needle tip, slide the transducer back and forth until you can see the needle and the tip in long axis. The needle, vein, and transducer must all be aligned in the same plane as the needle approaches the vessel. Dan is advancing the needle using short jabbing motions in order to avoid dragging tissue along with the tip. Once he gets to the vessel, a gentle poke will be all he needs to get into the vein. At this point, have an assistant freeze the image and save a copy or print it for the chart. Once blood is aspirated, the ultrasound transducer is set aside and the line is placed through standard Seldinger technique. Now we've seen both the middle and the posterior approach to IJ cannulation using ultrasound for guidance. The two most important concepts to keep in mind are to have the transducer in the proper orientation and to never move the needle if you can't see it on the ultrasound screen. If you keep these principles in mind, you'll make IJ cannulation a whole lot more comfortable for both you and the patient.